Good evening, everybody. It's now 1:06 here, 1:04 in Europe. So very warm welcome again to our regular EFISDS webinar series. Truly today is a very special webinar. Let me just share the screen and give some background. Working? Luigi is working?
Yes, it's working.
Okay. As a reminder, please, you are all heartily invited to become member of EFISDS. At present, still, although we have worked on the website, we will come to that in a moment. You need to just drop a line through the email to the secretariat and you will be registered as a member. And the membership is free for the first year and you will be informed how it will be in future then. We have worked on our website. It is still under construction. Some features are already available. Just go to the website, explore the content, and give us a feedback, what you are missing, what you would like to have. We will have very soon the option to register as members directly through the website, and you don't have to go through the additional email process. Today, our webinar is a very special global event. We are in collaboration with the Robotic Global Surgical Society, and the society is led by Professor Adel and Professor Rodolfo. Professor Adel is the president and the founder, along with Professor Rodolfo, of the TROGSS Society. This is the website. Please go and explore. Become a member of the TROGSS Society. Robotic platform, robotic surgery is going to play more and more a bigger role. And as per coincidence, also it happens that both of them are also today's speaker for our webinar. And I would like to invite our president-elect of EFISDS, Professor Luigi Marano, to give us a brief introduction of our speakers and to then hand over the platform to the speakers. Professor Marano.
Thank you, Professor Vashist. Professor Vashist is the chief of a research committee, scientific committee of EFISDS, and I really thank you for your commitment and efforts in organizing such a very interesting webinar. Today, as you told before, is a very special day because we are hosting two pillars of surgery all around the world, robotic surgery all around the world. Professor Oviedo from Texas Nacogdoches, and is the CEO of TROGSS, the Robotic Global Surgical Society, and Professor Abou-mrad from Orleans, France, that is the president of TROGSS. And I really welcome you both, friends and colleagues. We are very excited to have you on board today with us. And I will start this webinar giving the floor to Professor Oviedo and his presentation.
I think also just one remark in the current turbulent times between different perspective, America, Europe is going on. It is important then that we set an example and continue to set an example in the scientific field that these things are simply out of our framework. So science can only advance if we collaborate, if we cooperate, if we walk the path together. And that's why, especially taking the current scenario, whatever is going on politically, I think it sets an excellent example that we have someone from the States, someone from France, and a global audience to conduct this webinar. Finally, Professor Rodolfo, the stage is yours now.
Thank you, Professor Vashist and Professor Marano, for the very kind introduction. You honor us with this invitation EFISDS is so important to us at TROGSS, at the Robotic Global Surgical Society. It's our pleasure to present today. It's really a privilege. And as Professor Vashist said, I echo that. We are all human beings. We're all united by our desire to serve our patients and to advance surgical education and science. And so at the end of the day, we're all surgeons. And when we operate, when we're inside doing robotic surgery or laparoscopy or even with open surgery, when we see those organs, we see absolutely no difference between one human being and the other. We just don't know what the color of the skin is or what the nationality or what language they speak. We could go in and the organs look the same, so we're all built the same way. And so this is very important to us. We are brothers and we're here united. So I'm going to share my presentation and please bear with me. Can anyone see the presentation?
Yes.
Yes.
Okay, wonderful. So this is going to be a united presentation with Professor Abou-mrad and with me. We're going to do it as a dialogue between brothers, between friends, and a debate as well. And it's going to contain some personal stories that I'm going to give you. And I will do it to put everything in perspective because we are truly, truly convinced, and we have complete conviction that obesity is a disease, but not only that, it is a pandemic. And I'm gonna go beyond that. It's a curable disease and a curable pandemic if we all put our efforts into it. So we have entitled this presentation, The Forgotten Pandemic, Obesity, Curable Disease. First, our disclosures. We really don't have any relevant disclosures to make. And of course, the acknowledgement goes to EFISDS and to Professor Vashist and Professor Marano, without whom we would not be here today. So thank you so much. To begin, I remember I usually use this slide for my presentations on obesity. And these are old slides, but this is important because even from the time I was a resident physician more than a decade ago, I used to remember that I thought of obesity as a national problem in the United States. The United States has a problem with obesity, but it's really not the United States. This is a pandemic. It affects all of us. As a matter of fact, we know, and I'm going to discuss some interesting literature, that many countries in the world with low to mid socioeconomic status are the ones with advancing rates of obesity and morbidity and mortality. And it's not only affecting those countries, but also wealthy countries or countries that are truly more developed. And so it really doesn't matter where you're from. You could be from a low or mid socioeconomic status country, or you could be from a very well-developed country. Obesity affects all of us. And it is a disease that affects virtually every organ system in the body. I don't think we need to make emphasis on that. It's very obvious to all of us who treat patients who suffer from obesity and associated diseases. Now, the BMI is not a perfect way to measure obesity. We already know that. BMI takes into account the patient's weight and the patient's height, and of course, it's kilograms per meter squared. And when I was a medical student, we used charts. Nowadays, we use artificial intelligence. We use calculators online. It's very easy for our patients to be well informed and know what their BMI is. But BMI is not ideal. Of course, I treat student athletes from the local university. I treat football players. I treat patients who are baseball players and basketball players, and they're in really, really good shape. They have increased muscle mass compared to the regular population. And so their BMI could be higher. By all accounts, they could be overweight as far as the category, but they're not overweight. Obviously, they have a lot of muscle mass. And by the same token, if you are a tall person, it's more forgiving. The BMI is more forgiving, right? But if you are a short person, it's not as forgiving. And so we don't have a really good, accurate way to categorize the obesity based only on BMI. We have other measures, anthropometric measurements that are more accurate, but they're more labor intensive and they require more training and more time. And so it's not as easy. However, BMI is the easiest way that we have currently to categorize obesity. And as you know, in accordance with FASMBS and IPSO guidelines, we try not to call the disease morbid obesity anymore. So there is overweight, there is obesity, and there are classes of obesity. So we try not to say, please, for everyone on this webinar, important conversation, and one of the home messages I want to drive, let's be respectful of our patients. Let's be respectful of and mindful of the stigma of obesity. And let's make sure that we don't call it morbid obesity anymore. Some of the old slides are going to mention that nomenclature. Some of the papers I'm going to quote today, and Professor Abou-mrad as well, are going to say morbid obesity or weight regain or recidivism or terms like those that are only detrimental to our patients and to their well-being and dignity. Because if you think about it, we don't say morbid colon cancer. We don't say morbid breast cancer or morbid hypertension or morbid cardiovascular disease. So why would we call it morbid obesity? When we say morbid, it's almost like we're putting the guilt on the patient. And this is quite the opposite. We want to eliminate that feeling of guilt because obesity is not the patient's fault. Obesity is not the patient's fault. It's very important. I want to encourage everyone today, and with Professor Abou-mrad as well, together we want to encourage everyone to think about obesity as a disease, because it is. And not only that, think about obesity almost like you think of cancer. And if you think about it, obesity could be the mother of all cancers, because most cancers have been proven to be related to obesity as well. It's not the only cause, but it contributes significantly, as I'm going to show you on the literature. And obesity is a disease. We need to remember that, and we need to engrave that in our minds and in the way that we treat our patients. The objectives from this talk are very, very simple, relatively simple. We would like to establish why obesity is a pandemic that affects all of us, to identify obesity as a treatable disease, and to discuss the most efficient treatments for obesity as a disease. And if you can see this diagram, which looks like a cartoon, of course, we have different pandemics throughout the world. We just don't think about them. We have the diabetes pandemic. It affects so many countries, so many nationalities, so many people throughout the world. Cardiovascular disease. We had the COVID-19 pandemic, and we prepare for the next one, and we will face that as a human race together. But if you think about it, there is also the pandemic of obesity, and we just don't tend to see it that way. It really affects us all. Let's talk about the elephant in the room, however, and here's where we get into the personal portion of this talk. And I don't mean to be touchy-feely, not at all. This is still objective, but why not tell you about my personal experience? So first of all, is obesity my fault or a sign of my failure? Some of you may have heard that from your patients. I'm just paraphrasing, but maybe some of your patients may be wondering, is this something I did? Is it something I deserve? What did I do to deserve such a thing? And obesity, it's something that it used to affect me as a person. I was born a regular kid, but then I was overweight, and then I had obesity as a child, and then as a teenager, I got myself into shape, and I exercised a lot, and then I went into medical school, and then medical school, I was in the best shape of my life until now, and then I became a resident, and everything went downhill after that with the stress in the American healthcare system, with so many hours and duty hours and doing everything I could for my patients. I started to gain weight. And I then experienced obesity little by little. You just don't look, you don't realize it if you look at yourself in the mirror. But if you have beloved ones or family members or friends who haven't seen you for a while, and then they see you a year later or 2 years later or 5 years later, they notice the change. And it's really interesting. I was not overeating. I was not doing anything unusual. I was just being a normal human being who was aware of healthy nutrition habits and exercise. And even though I was doing absolutely everything, I still experienced progressive obesity. And so it is truly a disease. And as Professor Abou-mrad is going to discuss later on, he'll talk about some of the factors which are multifactorial. But remember, obesity is a disease that affects every organ system and tissue in the human body. Most patients with obesity, if they look for you as the expert in obesity surgery or obesity medicine or management of weight, most of them are not going to tell you that they did it on purpose, unless you're dealing with a sumo wrestler in Japan who needs to be that way because of it's a sport. It's such a well-revered, dignified sport in Japan, of course, unless you are a football player in American football who is a part of the defense team, etc. You can think of specific examples. Well, unless you're one of those in those categories, most patients are going to say, I did not want to be this way. I did not try that on purpose. I did not try to overeat. It's really a disease. It's a derangement in the metabolism. And we try to drive this message home in ASMBS and in IPSO. And there is a stigma associated with obesity. Ourselves at TROGSS, we are working on manuscripts dealing with the stigma of obesity, and we are going to present at ASMBS on that very topic. It's extremely important for all of us. As a matter of fact, it's one of the main topics for the American Society for Metabolic and Bariatric Surgery this year at the annual meeting in Washington, D.C. in June. And treating obesity as a disease enables patients to live longer, more meaningful lives, and to prevent multiple other diseases, including cancer. More to come at the end of the talk. But I've been saying a lot of things, and I'm going to ask Professor Abou-mrad, what do you think, my friend, about the multifactorial issues that have to do with obesity and the way that our patients react to it?
Well, first of all, I want to thank the organizer, Professor Vashist and Professor Luigi Marano for the invitation. And it's an honor for me to present here. I was at your society. And thank you, Professor Oviedo, for sharing this presentation with me. So as you said, and I agree with everything you said till now, and I agree further, but for now, obesity is a real disease, and it's a chronic real disease. And it's multifactorial, so it is not only, it is in some way a responsibility of the patient. It's not his fault, but it's a responsibility, because to get out of obesity, he must be responsible and he must have a decision to make. So let's look upon this disease, this complex disease, because it is really multifactorial. It can genetics has to say in this disease, because there's we take two persons and they take the same amount of food. One will have a high metabolism, and he won't get 1 ounce up, and the other one will be like 1 kilo up in his weight. So genetics has a great role and a huge role in obesity. It is behavioral. We have behavioral problems like the binge eater and the hyperphagia and all the disease, behavioral disease that can come and play a major role also in this multifactorial disease. So we can have also psychological problems. We have the stress, and we will see that society is also a major factor in making an obese person. So it's not only the responsibility of the person himself, but he has a role to do to get out of obesity. It can be hormonal. We know that in some case, like if we have menopause in women, they can easily gain weight after menopausal phase. So it is also age related. When we go through time, we gain weight as long as we go in time. It can be familial. There's a family obesity, familial obesity. We have family of obese. So it's like a pathologic behavior, but within a family. And the person within the family does not, he's not aware of the status of obesity. And when he look aside and see the difference with other people, he may consider the other as an anomaly. It can be cultural. We know that in some culture, when you are obese, it means you eat enough and you don't starve. So you have a status, a social status, and when you the more weight you have, the more status is considered for you. It can be environmental and geographical. We know that there are some regions with major obesity population, and it is especially a social disease, because everyone is responsible of the obese patient. Society is responsible of making obese. Agroalimentary industry is responsible. When we advertise for heavy sugar products, and when we incite the children to go on fatty food, we make obese person. It can be, as Rodolfo mentioned, economical. We know that it's not it's not specific for the countries with high income. It is also it's a pandemic in low income countries, because the quality of food they are taking is not the same. So it is multifactorial, and for this special disease, chronic disease, once again, our response must be also multifactorial. We must embrace this disease as a multifactorial disease in order to respond to this disease with the proper cure, and adjust the cure to the person. Rodolfo?
Wonderful. I agree, my friend. And it's really, we're all in this together. It's multifactorial. It has to be multidisciplinary. And just like cancer care, it must become multimodal. And we will talk about that, and we'll try to drive that message home for everyone. Multimodal therapy. Just like we treat cancer, we need to learn how to treat obesity the same way. And we need to separate obesity from the patient. Yes, it sounds ironic, but let's separate it. Obesity is the disease. The patient is a dignified person who needs the best care that we can provide to him or her. So sharing some personal pictures, that's me as a baby with my beautiful mother. And so I was born like any other kid, right? But then that's my beautiful wife on the second one. I was graduating. I proposed marriage to her on the day of my graduation as a surgeon. But then I started gaining weight, and then she was pregnant with our first son, Joshua, who's 7 now. And so I was already beginning to gain weight, and that was years ago, several years ago. And then that was me on the last one presenting at Manchester at the European Hernia Society, probably 4 years ago. And I was already undergoing the next phases of obesity, class 2. And so I ended up changing my life. When I got to that point, even though I was trying the best that I could, and my family was very supportive of me, and they knew my best efforts were not being productive, I underwent metabolic and bariatric surgery. It changed my life. And yes, I am a metabolic and bariatric surgeon. I'm proud to be. But one thing is to be the surgeon, and something different is to be the patient. And being the patient gave me a whole new perspective that I was not aware of. And now I feel like I understand it even better, and I embrace it better. And I was humbled by the experience. I had a wonderful experience. I underwent robotic, metabolic, and bariatric surgery for medical reasons. It wasn't really so much for the weight, because we need to learn how to see this disease as a disease that affects every organ system. It's really a health status issue. It's not a cosmetic operation. It's not a cosmetic issue. It's not because of weight. Weight is just one element of it. I was beginning to experience medical problems that I never thought I would have, including hypertension, hyperlipidemia, the early stages of OSA. I'm talking about hormonal changes, everything that has to do with obesity. So I underwent surgery. I had a wonderful result. I went overboard because I was disciplined enough that I lost more weight than I was supposed to just by the operation. But as you know, depending on the surgery that you end up choosing, you could have 60% excess weight loss. In my case, I went beyond that, but because I embraced karate as a discipline, as a martial art, and one of the pictures, I'm there with my master, who's a 6th-degree black belt. I'm there with my beautiful, wonderful parents in San Antonio at the International College of Surgeons ceremony. In the middle, I'm in the OR, the photo taken by one of our wonderful observers from TROGSS who visited us in Nacogdoches. And then I'm with my beautiful family on the right side, my wife, Candy, and our 3 wonderful sons. So life has changed for me. I am a new person. It's been 2 years, and I am still trying to be disciplined and live a healthful life and be a person who is cognizant and aware of his surroundings and nutrition habits. And I try to embrace exercise and healthy nutrition habits as much as I can. It's demanding being a surgeon, as you know, but I am in this struggle together with my patients, and I am very, very happy with the outcome. So this is just something personal I wanted to share. And just one last personal thing. This is karate. I'm performing the kata called Heian Yondan. Heian Yondan is the peaceful mind number 4 for Shotokan karate. And so here we go, just to see. Years ago, I would not have been able to do anything like this because of the chronic fatigue that I was experiencing.
Take care of that. That is great. I never think about that. Maybe that's my gift. I mean,
As we can say in karate, os, respect. So that's one of the things that I have embraced. But let's talk about something more objective. Obesity is getting worse. And I don't mean to be pessimistic, but I recently had the honor of participating in this global study led by Professor Minghua Zhang from China and Professor Wai Yang, one of our esteemed members from TROGSS. Professor Wai Yang is a member of the research committee at TROGSS, and he's also a member of the executive council, like Professor Vashist and Professor Marano. And Dr. Wei Yang and Dr. Elena Ruiz Ucar, who is also one of our esteemed members from the Executive Council. She's the co-chair of Membership and Engagement. We participated, and it was a study based on the Global Burden of Disease Study 2021. We decided to analyze the burden of disease attributed to high body mass index. And we encountered some interesting findings, such as the fact that from 1990 to 2021, talking about just a few decades, the global deaths and the DALYs attributable to high BMI increased more than 2.5-fold. What is a DALY? The DALY is the disability adjusted life years. And so if we think about it, when we analyzed the DALYs from 1990 to 2021, we found that the age standardized DALY rates, or the disability adjusted life years, increased by 22% for females and 31% for males. But also, the age standardized death rates were stable for females, but they increased by 15%. And we found that the high BMI attributable DALYs were due to diabetes, ischemic heart disease, hypertensive disease, chronic kidney disease, low back pain, and stroke. So obesity is actually getting worse, and it's also affecting countries of low and mid socioeconomic status. The rates have increased significantly from 1990 to 2021, and therefore there is an urgent need for us to do something about it as a society, as a professional society, as a collaborative society with the EFISDS and with other multiple professional societies, and also with stakeholders from the government level. It's very important for us to act and to do something about obesity, and we are trying the best that we can, but we can do so much more. Professor Abou-mrad, give us your perspective in terms of medical management of obesity. I know it's not an easy solution. It's not like checking with Google or ChatGPT and it's going to tell you what medication to take. It requires much more, doesn't it? It requires medical knowledge, all of these years and decades of knowledge and wisdom that we have accumulated with medical school and our training. It's not as simple as Googling something, is it?
Yes, indeed. But we must remember that before becoming surgeons, we are physicians, we are medical doctor. So when we think about our patient, when we manage our patient, we must manage the whole patient, not the surgical part alone. So we must consider the patient as a whole unity and try to answer his demand, because when his patient comes to us, he's asking for something, and the answer is not always surgery. It can be surgery, it can be medication, it can be behavioral education, it can be a dietitian procedure, and it can be surgery, all the combination of all. As we take in charge our patient, we explain surgery for the patient, but we explain also how to go beyond borders in order to go out of the obesity. That in clear, we must educate him, we must send him to the dietitian, and he must have the will to go out of obesity. And this is not easy. This is a decision that he must take. So we must take all what is given to us in our arsenal against obesity. It means surgery, it means medication, it means behavioral education, it means including all the partners, all the physicians that are implicated in this pathology, because it is multifactorial. Our response must be also multifactorial. Surgery is like a cutting in, and it's intrusive. So it must be well prepared, it must be well think, it must be well constructed. And we have now
endobariatric procedures, Professor, right? Endobariatrics is also part of the treatment modality.
Exactly, exactly. So we have now the GLP-1, which must be considered as an added value in our fight against obesity. It means we as surgeons must embrace it and use it to the best of our patient interest. For me, it can be used if the patient asks. We must give him all the answers at our disposal. And if he chooses only to have the GLP-1, we must give it to him, and we must help him and follow up with him in order, if it fails, to be ready to go further. So it can be before surgery. If the patient is only to take the GLP-1, we must give it to him. If there is a contraindication for surgery, or if surgery does not fit, we must give him an answer, because if he comes and asks for a solution, it means he is in suffering and he's demanding something, and we must answer it. It can be also for us a way for higher BMI person to lose some weight, to prepare surgery, and to have a better and more easy surgery to be done. Postoperatively, if our patient doesn't sufficiently lose weight, we can help him in some period in order to lose more weight and to regain energy in fighting this disease. So in postoperative patient, when he's on a stagnation period, we can help him to lose more weight and go further. And when we know that some patients of ours will regain weight after some years of follow-up. So those persons, we can put them on the GLP-1 in order to re-lose weight and to regain confidence in themselves, and to take them in order that they take themselves in charge with our help. So GLP-1 must be considered not as a replacement of surgery, but as a complementary way to help the patient. Rodolfo?
In fact, my friend, I think that we need to learn how to think about anti-obesity medications, including GLP-1 agonists, as adjuvant or neoadjuvant therapy. And yes, I keep saying this, that we need to think about obesity as we think of cancer, because just like we have neoadjuvant or adjuvant chemotherapy and radiation, we can do the same with this. And so we utilize the metabolic and bariatric surgeons. As you know, you and I are both metabolic and bariatric surgeons. We have learned to use these medications and endobariatric procedures, which I'm going to discuss very shortly. We have learned to use them as neoadjuvant therapy to prepare patients as a bridge to metabolic and bariatric surgery, or we could use them as adjuvant therapy, meaning, as you said, when there is weight stagnation or weight recurrence, what we used to call weight regain, and now we call weight recurrence. Same thing. We can actually put the patients on these medications and we can make them lose additional weight and go back on track. So this is very important. And yes, we all know that they're very effective. These medications are highly effective. However, we have a whole multitude of challenges in terms of socioeconomic status. The cost in countries like the United States are extremely expensive. Our Medicare, our health system, our health system does not cover a lot of those, and they have put insurance companies have also put in a lot of demands in terms of the criteria so that they can pay for them, and it's becoming increasingly difficult for doctors to prescribe these medicines for their patients in our country. And now we have the phenomenon of compounding pharmacies that are making the compounded or non-FDA cleared formulation that utilizes the same compounds. And so it's a whole controversy that we can discuss at another time. It's not really the main purpose of this talk, but it's just to put it in perspective. It's not as easy as it sounds, like I'm going to get an injection, I'll inject it into my body and I'm going to be fine. No, it's not for everyone. Everybody's different. You may develop severe side effects that may be a contraindication. You may have contraindications to it, absolute or relative, or you may also develop side effects that will prevent you from losing weight and continue to use the medication. And now what do? Well, you are still a candidate for something else. For example, endobariatric therapies like intragastric balloons or endoscopic sleeve gastroplasty. And I'm going to show some interesting videos about that. Let's talk about the literature just a little bit. You were mentioning bridging therapy. That's very interesting. We have this important manuscript that came out saying that it's talking about the weight loss effect of GLP-1s with endoscopic bariatric therapy and bariatric surgeries. This was based on a systematic review. It was an article that came out in the Journal of Endocrine Surgery just 2 years ago in 2023. The interesting thing about it was that the authors found after this systematic review that actually combining GLP-1s with endoscopic bariatric therapies, according to the authors, that has the same effect as metabolic and bariatric surgery. That sounds interesting. I would caution though, it's not as easy as it sounds, because then patients may think, oh, okay, great. So if I just take GLP-1s and I do an endoscopic bariatric procedure like a balloon or ESG, I don't need metabolic surgery anymore. Well, it's not that easy. This is based on a systematic review that was not an umbrella review. So it's not based on a systematic review of systematic reviews. This was based on a lot of observational studies. A lot of them were retrospective studies or case series. So take it with a word of caution. It's an important study. We learned a lot from it, but not everybody will respond the same way. However, it's important to know, as specialists in obesity medicine and surgery, that yes, combining GLP-1s with endoscopic bariatric procedures may have an effect almost as powerful as surgery. But at the end of the day, it's a continuum. We can't just put one tool against the other one. We would be foolish to do that. We need to be wise. We need to embrace all of them. It's almost like saying chemotherapy is better than surgery and it's better than radiation therapy for cancer. No, we consider all of them as part of the whole spectrum of treatment for these patients. And then we have another study, the effect of GLP-1 receptor agonists on weight loss following bariatric treatment. So this was based on the same Journal of Clinical Endocrinology and Metabolism, but last year, 2024. Interesting study. This was a systematic review with meta-analysis. talking about the effect of the GLP-1s on weight loss following bariatric treatment, because they analyzed patients who had already undergone metabolic and bariatric surgery, and they found that the participants were able to lose additional weight thanks to GLP-1s. And so this is also interesting. As I said, you can use them as adjuvant therapy. And then another interesting study, this is really, really cutting edge, and I love this study. Fast-track rescue weight reduction therapy to achieve rapid technical operability for emergency bariatric surgery in patients with life-threatening, inoperable, severe obesity. This was from Professor Christine Stier and Sonia Chiappetta and a phenomenal group of endoscopic bariatric specialists who analyzed the issue of what happens when you and I, Professor Abou-mrad, went to operate on a patient with significant obesity. I'm talking about obesity class 5, BMI of 60, what we used to call super morbid obesity. After 50, we used to call it super morbid, trying to eliminate those terms. 60 BMI is class 5. So when we have a patient in that category, how do we actually take them to surgery? In a lot of ways, we are limited by the beds in the hospital, by structural, by engineering, by the operating table, by some logistical issues, by the toilets in the room. I mean, logistical issues that sometimes we don't think about because we're surgeons, but we should, right? And as directors of our programs, we need to know that. We need to engage in conversation with engineers as well and know what the hospital can handle. So what do we do when we have a patient in that category? Well, the interesting thing is they thought about it and said, we could do a balloon, but not everybody's going to afford a balloon. We could do an endoscopic bariatric therapy to prepare them for surgery as a bridge. Or we can put them on a GLP-1 with a hypocaloric diet, and let's see what happens. And guess what happened? They put them on that treatment for several weeks. They found that the patients were able to lose 27.5 kilos on average. That prepared the patients to be in better shape, so to speak, and a better BMI, more appropriate to be handled surgically. So they were able to achieve the impossible by putting these patients on neoadjuvant GLP-1 therapy. What do you think about that, Professor Abou-mrad? Interesting, isn't it?
It's really interesting, and it's a great paper. Let's say that, as I said, we must consider every way of fighting obesity when we take in charge of patients. Endoscopic surgery, endoscopic bariatric surgery is one of those weapons. And when we combine GLP-1 with endoscopic surgery or bariatric surgery, we must potentialize the effect, and I'm sure we will help our patient to lose weight better. What you said about the cost is a real problem, because there are many patients that cannot afford the cost of GLP-1 or the cost of endoscopic surgery. And this is a real problem, because we cannot give them the whole potential of our arsenal, of our therapeutical arsenal to achieve the goal of weight losing. And when we consider the issue of the GLP-1 alone, we can achieve nearly an average of 20% of weight loss. We have heart protection. Some papers are speaking about enhancing brain function and delaying Alzheimer's disease. It's efficient on diabetes. So it's a good way to help people, but its cost is a problem. And I think if we embrace the obesity as a chronic disease in a state of pandemic, it's a real health, government and public health problem. And the cost of obesity is far more important than taking in charge the cost of GLP-1. So when we have apnea syndrome, we must give the patient a machine in order to help him sleep well. We have to treat diabetes. We have to prevent liver disease. We have to prevent articular problems, and most of all, the patient lose his autonomy and his productivity. So if we take the economical impact of the obesity disease, it's huge. And comparing to the cost of the treatment, it's nothing. So if we have an efficient health policy, we must take in charge the cost of the GLP-1 and related treatment in order to prevent what is being paid for the comorbidity induced by obesity. The problem also is the duration of the treatment. We know how to start GLP-1. We do not know when to stop it. We can stop it if it is not efficient, if the patient regained weight, if overweight relapsed, as you said. If we had some side effects, and we are starting to have some articles and some works citing some minor side effects, important side effect, but it's rare. So if we take in consideration a health politic and the health problems, a general public health problem, we must be aware that taking in charge the cost of GLP-1 is nothing in regard of what obesity cost our society.
You said very well. Obesity, the treatment of obesity, even with surgery, at the end of the day, is going to be more effective many times compared to just being on medication. And so the DALYs will improve. All those disability adjusted life years, or those years of life that are lost, all those years of life that are lost because of cardiovascular disease and cancer and other medical problems, they'll be regained, and patients will have a better life and they'll have a longer life expectancy. And so that will improve. Another important study talking about the same topic in GLP-1s, this study came from Switzerland. They took patients who underwent metabolic and bariatric surgery. Now, this is not a systematic review. This is a retrospective observational study from Switzerland. Took patients who underwent metabolic and bariatric surgery, but then they experienced weight recurrence, what we used to call weight regain, now weight recurrence. And they put them on GLP-1 medication, and the patients exhibited weight loss. At least 2/3 of them exhibited weight loss. So it was successful in 2/3 of the cases. So that's not bad at all. It's something that we can do as part of the multimodal therapy spectrum for our patients. But I think probably that's enough of the GLP-1s. Why don't we talk about something as exciting or even more exciting to me, which is endobariatrics. Are we ready for this? So balloons. Let's talk about endoscopic therapies, including the intragastric balloon. We're not here to endorse any particular company. We're just going to show one of the examples, and special thanks and my deepest gratitude to Professor Manuel Galvao Neto, one of the superstars in the world of endobariatric therapy. And so Professor Manuel Galvao Neto provided these videos. So these are his courtesy for EFISDS and for TROGSS. So my deepest gratitude to him for this. I'm going to show a video of the intragastric balloon insertion. So in this particular case, the patient is not under, this is done, in this case, the patient is undergoing this under TIVA, or total intravenous analgesia, not intubated with endotracheal tube. They're going in, they're doing an EGD. As you can see, no significant hiatal hernia. They're just examining, making sure there's no severe peptic ulcer disease. And now they're going to select the site where to implant the balloon. You can see the inlet video shows the professor performing the endoscopy. The patient is in left lateral decubitus position. They're about to insert the balloon. He's just teaching his fellow, looking at the Z line or the squamocolumnar junction. No severe Barrett's esophagus, nothing like, no major contraindication. Now the scrub technologist or assistant is showing the balloon, the catheter that is connected to the balloon. And then it's going to be introduced blindly. You follow the curve. Sometimes anesthesia may perform a jaw thrust maneuver. You introduce it with lubricant. That's very important. It goes in blindly. There is a bi-block piece in the mouth to protect the teeth. and the structures in the oral cavity. Then you introduce it blindly, it's gonna go, and then you place the scope, and with the scope, you advance it blindly, very carefully. Of course, are there cases in which it may go into the trachea? It could happen, but it's extremely rare if you follow the contour of the throat, of the pharynx. It should not happen. So, of course, before trying anything, if the patient is desaturating or having any distress, put in the scope, make sure you're not going into the trachea. But once you go in and you insert it into the stomach, you leave it there, then you're going to have a device, a two-way valve. You're going to connect that catheter, and with a bottle of solution of saline, you're going to inject manually. Yes, you could use a pump, but manually you inject the cc's of saline into the balloon to fill it up. And this is one of the commercial products. I'm not going to endorse any particular product. I'm not going to say the name, but it's just one example. And so now we're going to connect that saline, showing the equipment. We're going to connect it to the catheter. We're going to manually push 500 cc's, etc. It all depends on the manufacturer. Everyone is different. There are companies that make a dual balloon. There are companies that make this type of balloon that accommodates anywhere from 400 to 600 cc's. There are companies that make a balloon that you just swallow. You don't even need endoscopy to put it in, etc. It's just an example. I'm going to fast forward. In the interest of time, I'm going to fast forward just a little bit to show how they're manually drawing fluid from the saline container or the bag, and now they're going to use the valve, flip it, and then they're going to push to fill up the balloon, and that's what's being shown. Really, no offense to anyone, but I mean, it's not that complicated. It's not rocket science. It should be relatively simple to do. Honestly, the most important thing is safety, 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 safety. So make sure there are no contraindications to placing the balloon. A giant paraesophageal hernia, active peptic ulcer disease, obviously malignancy, any type of tumor, anything that will make the patient sick, pancreatitis, any pseudocyst, obvious reasons, or severe Barrett's esophagus, etc. Because there have been some reports that GERD may be exacerbated by the foreign body in the stomach that will stay there for 6 months. And are there perforations? Are there risk of bleeding, perforations, or catastrophes in the abdomen? Well, extremely rare, extremely rare. Actually, the most common side effect is what you can imagine: nausea, maybe vomiting, maybe intolerance to the balloon. Are there reports of spontaneous rupture? Very rare reports. It could happen, but it's very rare. So this requires multidisciplinary care with the dietitian, with the psychologist, and everyone else in the program. And at 6 months, I'm going to show now the removal. The removal, Professor Manuel Galbao Neto provided this as well. The removal, 6 months later, you go back in, and now is a different story. You see the balloon is usually going to be covered by gastric secretions. It's going to look more green. Then you go in and you have a special catheter. You're going to insert it and puncture the balloon. And when you puncture, then you're going to aspirate the contents. You can use a suction device. And then to grasp it is a different story. I'm going to show, the professor is showing the technique right here, making sure that the scope is not getting stuck. He's going around the balloon to go towards the antrum, because the balloon hangs out in the body of the stomach and towards the fundus. He's just trying to go around, and he's doing retroflexion maneuver. He's checking the pylorus, and then he's going back into the proximal portion of the stomach, and now he's going to insert the catheter. And with the catheter, with the needle, they're showing that right now, they're going to aspirate the contents. And so this is usually done 6 months later. However, this requires monthly visits. It requires tracking of the data. The patients have an app where they can communicate with the physician and the program, and they can track their weight. It requires a lot of intensive labor and care from the team so that patients don't have complications that we can regret later on. So it's very important to keep communication with the doctor and with the team, and not to forget about those patients. I know they're not surgical, but it's extremely important to keep track of everyone and their progress so that we don't have complications to regret later. So they're showing how the needle goes in, and now they're going to puncture, and then they will connect it to the suction device, and they're going to suction the contents. And then I'm going to fast forward just a little bit more. For the sake of time, they're suctioning all the fluid, and when it's empty enough, let me show it. There you go. Now they're going to go in with a special grasper to grab the balloon and pull it out. And I'm going to show that right now in just a second. Going in, right there. This is the type of grasper that they're going to utilize to grasp an edge of the deflated balloon. There you go. So I'm going to show that right now in the video. Going into the channel, and right, they're just looking for a fold that is big enough so that they can grab right there. Of course, being very careful not to cause any damage to the mucosa of the stomach when they do that. Once they do, it's so well secured that then you just come out with the scope, and then you drag the catheter and the balloon with you, and the rest is history. So it should be relatively straightforward, but of course, sometimes they're showing here that sometimes when that happens, the patient exhibits tachycardia, but I mean, as long as you do it very carefully and you're watching the mucosa, you're not injuring anything, it's a very safe procedure. Here it is, and it's coming out. Right there, you're just dragging it like you would drag a foreign body for extraction. And that's it. Finally, one more technique, the Brazilian technique, with a modification from Dr. Andre Teixeira. Dr. Andre Teixeira from Orlando Health in Orlando, Florida, United States, who's partners with Professor Manuel Galvao Neto. What they're using is oil, cooking oil, like canola oil, to be able to lubricate it so well that now you don't even need that special alligator clip. You just need a regular forceps. And so I'm going to show you that. They're using some oil. They puncture it. That's how it looks.
So there we gain access.
That's how it looks when it's covered with gastric secretions 6 months later. They're aspirating. That's similar. But now what they're going to do is they're going to use canola oil, cooking oil. It's so easy now that they decrease the friction, and now they're going to grasp it with a regular grasper device. There you go. You don't have to use that long device. And now it's very easy to drag. There you go. And the rest is pretty easy to do. So that's about the balloon. Really nothing much more. Let's talk about two papers that are very interesting regarding the balloon, Professor Abou-mrad. One of them is intragastric balloon as bridging therapy to metabolic and bariatric surgery for patients with obesity class 4, BMI of 50 or above. This was a systematic review, meta-analysis. It came out in Obesity Surgery, the official journal for IPSO. It was in 2022, so it's a relatively recent study. And really, the complication rate was 8%. And we talked about it: vomiting, nausea, adverse events. Severe adverse events are rare. Yes, you could have a perforation, conceivably bleeding, but it's extremely rare. It's very well done. And it's an effective bridging therapy so that patients can lose enough weight so that they can qualify for metabolic and bariatric surgery. What do you think about this, my friend? Do you think it's something worth looking into as bridging therapy, just like GLP-1s?
Well, balloons is another weapon in our fight against obesity. There's some issues with the balloon. Its cost is sometimes a problem for the patients. And its effect is temporary. So it can be a bridge in order to facilitate surgery and to go with another procedure in order to consolidate or to achieve more weight loss. It's sometimes, and this is the problem with the balloon. It is practiced. It is inserted by gastroenterologists and other physicians that does not prepare the patient as we prepare it for surgery. We prepare our patient for surgery for at least 6 to 12 months before coming to surgery. So they had a psychological evaluation, dietitian preparation. They have pneumological exploration, cardiac exploration, and so on. So they are taken in charge, and we know that it's not only surgery; it's the preparation and the follow-up of surgery that make weight loss a long-term duration. If we only consider the balloon as a gesture to lose some weight and we take it out, we will have the same status of BMI some months later after withdrawing the balloon. Another thing is that it needs 2 general anesthesia and some manipulation to be done. I don't know if you are aware of some balloons that we can swallow. This may simplify the procedure. But what is especially interesting in your presentation is that gastroscopy search for contraindication for the balloon. When so it is not a simple gesture. It is a good one. It's a bridge, as you mentioned. Or if we prepare enough our patient for the next step after withdrawing the balloon, we can achieve a long-term weight loss. And you mentioned complications. There are some complications sometimes important. So we must follow our patient. We must guide them, and we must be aware of all of that, even though for a balloon.
Absolutely. And talking about the balloon, let's compare it to another endoscopic bariatric therapy. And yes, just to clarify, some groups do it not under general. You could see the vocal cords in this case. Some groups like Professor Manuel Galbao Neto, they do it so often. They're so good at it because of experience, skills, and volume that they do it under TIVA, or total intravenous analgesia. So not even an endotracheal tube, but not everybody does it that way. You're right, and it requires a lot of resources and more money and general anesthesia, etc. But to compare the balloon to the ESG, or endoscopic sleeve gastroplasty, ESG wins. Of course, it's more durable. It's not something that will come out of the body later, and the patient may experience weight recurrence. I almost said weight recurrence. And it's something that is almost as powerful as sleeve gastrectomy, surgical sleeve gastrectomy. But it's an interesting thing. And so when you compare the two of them, we have this important study, intragastric balloon versus ESG for the treatment of obesity. This was a systematic review with a meta-analysis that was published in 2020 in Obesity Surgery. Again, the official journal for IFSO, the International Federation for the Surgery of Obesity and Metabolic Disorders. And this was a very good, well-done study that was based on 28 studies. So many patients were included in the study, and they found that although both modalities, endoscopic sleeve gastroplasty and ESG, are safe and they're effective for weight loss, really the ESG will win. When you compare the two of them, ESG has a greater weight loss, more durable weight loss, and more profound metabolic profile compared to the intragastric balloon. As a matter of fact, ESG is more of a durable one-stage procedure. If you think about it, intragastric balloon can be considered more like a bridging therapy to something else. Now, can patients have it and not undergo surgery later on? Sure, that's their choice. But ESG tends to be more durable. And the beautiful thing about it is that ESG can be modified. It can be revised into something else. And some people argue that it is actually reversible. So it's very interesting. So what do you think about this one?
Well, I am really for endoscopic surgery because it's and you mentioned reversible. If we consider a procedure to be reversible, I think there's something wrong, because if we have a chronic disease in front of us, it's not a status that we will heal. It's a status that is related to many factors concerning the patient. So the reversible quality is not an issue, because if we go for a procedure seeking reversibility, it means there's something wrong. We don't know. We are not giving the patient the answer he seeks, because if it is reversible, it means he will go back to the first status before surgery or before the procedure, which is not the aim of the patient. The aim of the patient is to lose weight permanently. So if we are thinking at first of the reversibility of the act, it does not fit the procedure and the engagement we are with the patient. So we must give the patient something permanent in order to respond to this chronic disease. It is a disease. It is not a one-time incident and it will goes out. It goes away. It is a status that will go with the patient during all his life. So what we are doing is to keep him in the healing status as long as we can. So reversibility is not an issue for me. Yes. And endoscopic surgery is a good way to treat the patient if he has the criteria that fit too.
Just a caveat, just to be the advocate for the contrary. The caveat to that is that some patients, they will not do anything unless you tell them that it's reversible. That's an issue for them, mentally speaking, and they will not do something that is permanent. They are seeking something reversible. So everybody's different, and it's something to think about. So if they want something reversible, balloons make sense, or something that is not as definitive, for example, as a metabolic and bariatric operation that has a more profound effect on the metabolism and absorption, etc., and it is more of a lifelong commitment, as it is in my case as a patient. So that's really interesting how patients have different expectations, and it's our job to come into this partnership with them and make them understand the pros and cons and implications as well. And just to mention this group, phenomenal group from Brazil with Professor Manuel Galvão Neto, I highly recommend this paper on intragastric balloon. I could show so much literature on YouTube, but this one is impressive. More than 40,000 cases. This was published in SWORD, the official journal for the FASMBS. And this was in 2018, so it's a little old, but this one talks about their recommendations and guidelines for how to place and remove balloons. So highly recommended. We can discuss it at a later time as well. And why don't we talk about ESG? I know that you, Professor Abou-mrad, participated in a French study that talked about ESG and advocating for ESG and the recommendations from SOFCOM, the French Society for Obesity Surgery and Metabolic Diseases. I'm just translating from the French into English. And of course, tell us a little bit about that, and that way we can show some interesting videos and then literature about ESG.
Well, endoscopic sleeves, endoscopic surgery is somehow taking the step. It can be a major weapon to treat mild obesity. And it can be, if we don't have much experience over the time, but I think it can be a bridge also. But it can be a permanent solution for some patients. What is important is to choose the patient that fit this procedure in order not to discredit it. So we must really explain to the patient what he is expecting from this procedure and what next step we can have if we don't match his expectation. But it is a good procedure, and many surgeons in France are going towards this issue because it's like a scarless procedure, and this is something valuable for some patients. And I think it can be extended. We don't have the authorization in France to do it for lesser BMI, but it can be used for a patient with the 30 to 35 BMI in order to achieve the weight loss he's seeking. It can be used also for higher BMI with some contraindication for the bariatric surgery. So it's a domain in continuous and expansion and development now, and I think the future will tell us more about this procedure, because it is going to be more and more affinate and more accurate and more specified for a certain type of patients.
Absolutely. And this brings back memories. When I was doing my initial training on ESG, and I was practicing in a dry lab model, inanimate model, etc. And so, you know, just practicing and practicing, and practice makes perfect. And then we continue to learn with every single case. So I'd like to show some interesting short videos. Forgive the fact that this was taken with a phone. I still did not have capabilities for endoscopic recording back in the day. So I had to use a phone to record on the screen, but you can see some of that. Of course, patient identification has been deleted, so nobody will know. This is just based on a procedure, one of the first ones I was performing. And here we can see how to choose the site for the first bite. This was a patient who had undergone a sleeve before, but the patient underwent weight recurrence and the sleeve had dilated, unfortunately. So I wanted to do a revisional endosleeve. So if you think about it, revisional, it's like a re-sleeve, but endoscopically. So I'm trying to decide where to put my stitch first. The antrum was okay. That's the incisura. You see it at 3 o'clock, incisura. So once you pass the incisura, at that area is where I'm going to select my first bite, to then march from distal, from the incisura, all the way up to before you get to the proximal portion of the sleeve. Obviously, this person had a sleeve, so there's no fundus. But in ESG, we leave the fundus alone. It's really interesting. We don't do anything to the fundus. And I think a lot of that has to do, nobody has been able to give a clear explanation of why, but I think honestly, being a surgeon, not a gastroenterologist, all due respect to my colleagues, I love my GI colleagues, okay? But being a surgeon gives me a different perspective, like you. And we know what's on the other side of the fundus. You and I know, Professor Vashist knows that, Professor Marano knows that. We know the spleen is on the other side. We know exactly what's going to be there. We know the short gastrics. And so I think we tend to not do anything at the fundus when we do ESG, because of that fear of causing injury on the other side and causing major bleeding from the spleen. And so I think it's a word of caution. When we do ESG, we tend not to do anything at the level of the fundus. In this case was different, right? Because it's a sleeve. But if you're dealing with a native stomach, you perform your suture placement, your U-stitch. There are different patterns. We can discuss that at a later time, but it's been shown in the literature that multiple patterns don't make much of a difference. But the U-stitch in the United States is the most accepted, and that's what I did in this patient, literally a U. And when you do several U-stitches and several from the level of the incisura down to the short of the fundus, you don't do anything to the fundus, usually that achieves the goal. And so I'm going to choose now the first tissue bite. You can see it involves using that helix. You see the helix right there, and purchasing that tissue. The helix gets encrusted. You pull the tissue towards you. You need an assistant to help you with that part. And then you have your needle driver. You clamp, that engages the needle driver. You push the needle driver and the needle, you engage with the suture, then you pull, and then you open the needle driver, and that achieves that bite of tissue, and that full thickness bite. And you're about to see that when you release, it's engaged. And now you have to exchange. I'm exchanging the needle, ready to go. I'm ready for the next bite. Now I'm gonna go in the direction of a U, going up to down, to down, to up, to up. When you make your U, what you're doing is you're cinching down the diameter to a smaller diameter. Now you just have to repeat that probably 6 more times, or 7, or up to 8. It depends. How many U's do you want to have? It depends on the patient's anatomy. And there are beautiful literature evidence that tells you about the patterns of suturing and how you can do it. But in reality, keep things simple. Surgery should be simple. I didn't say easy. I said simple, as you know. And so we try to keep it very reproducible. So that U pattern is what seems to work. Now, one more. This one is going to show you even more bites. You can see how the helix is already encrusted. You see how we're narrowing the diameter of the lumen already? I'm bringing that tissue up towards me. My assistant is managing the helix. Now I engage and I'm going to go with my hand and clamp, and the needle purchases the tissue. I now have my needle driver. I push the anchor, I release the anchor, then I open, and that's going to allow the tissue to be pushed away. The helix comes out into the instrument, into the device. I'm not going to say the name of the device, but everybody knows it. And we're not endorsing any company, of course. But in reality, this is reproducible. You need one person at least helping you. That could be a scrub technologist or a nurse, just to manage that helix, because it becomes cumbersome. If you have the device and you're the one managing the helix, you could have a medical student doing it. You could have a fellow. And then, of course, you could be the one managing if you give the instrument to your fellow. So it all depends. This is a perfect procedure to teach if you have a residency program or fellowship program. And so, as you can see, what we're doing with this, with the helix, with the needle driver, with this mechanism of this sewing machine, so to speak, we're doing everything from the mouth. We're achieving a gastroplasty, not a gastrectomy. We're not removing anything. We're simply modifying the diameter of the stomach to make a sleeve out of this plication technique, of this suturing technique. You can see that the lumen is being narrowed right here. And this is the perfect lumen that we want to achieve on this patient who had already undergone a sleeve and experienced weight recurrence. So this is just an example of what we're able to do. And now to show you the last one, anchor deployment. Let's say that we're satisfied. We're going to finish the U, right? This is one of the U's. Now we push the instrument so that we're going to cinch it down. The assistant is helping us with that part. We're cinching, and then we release that anchor, and the little anchor goes out, and that this is the mucosa comes towards you when you're in that process. But after that, you keep insufflating. It's very important to mention that it's under CO2. Extremely important. We're not using air, because chances are if you use air, you're going to have severe peritonitis. Some of that air that you're insufflating, these procedures could take up to an hour sometimes. Sometimes they could even take you longer than it takes you to do a sleeve robotically, believe it or not. And so it's important to use CO2, extremely important, because if you use air, you're going to have potential serious complications and severe peritonitis. So it's very important to use CO2. And now we're going to cinch it down and we let go, and that's it. Now that's the anchor. That's one U stitch. One U stitch takes about 5 bites. So one more time, one U stitch takes 1, 2, 3, 4, 5 bites. You let it go, and then you repeat 6 more times or so. And that's your endoscopic sleeve gastroplasty. I did this one with general anesthesia. Some groups have even described doing it under TIVA, no general anesthesia. I did this with general, and I had no problem with that. This patient stays in the hospital for a few hours and goes home the same day. It's just an incredible thing. We put them on a similar pathway compared to the sleeve surgical patients. She's doing incredible. She's doing very well, and she's very happy with the result. It's just an example of what we can do, and this is the diameter that we achieve. Any comments, my friend, about the ESG?
Well, I think it's a good procedure, and with the gaining skills, it will give the same result as sleeve gastrectomy.
Talking about that,
fond of it.
Yeah, and talking about that, you said you are hitting the nail right there. You're saying same results or similar results. Professor Marco Raffaelli, our friend from Rome, he's one of our executive council members. Professor Raffaelli performed this interesting study, and this was also this was published relatively recently. This was a study from 2020 in Endoscopy International Open, and this was 16 studies were done in the systematic review, and they found that it's almost as good as the sleeve gastrectomy. They compared ESG with laparoscopic sleeve, not necessarily robotic, but laparoscopic, almost as good. Very interesting, with a very low complication rate, very reproducible. And of course, yes, the surgical sleeve won, if you think about it, because the weight was higher with the surgical sleeve, but still with the ESG, it was very, very, very good. With the surgical sleeve, the excess weight loss was in a year was 80%. That's pretty good. That's similar to what I achieved. So far, so good. But with the ESG, it was not bad. It was 62.2%. I mean, if you think about it, that is pretty similar, like you said, to surgical results. Only time will tell what will happen.
Exactly. Time is a good
Good judge.
A good judge. But the thing is, we must consider it as a multidisciplinary approach, and we must consider sleeve endoscopy. The patient must be prepared as for a sleeve gastrectomy and must have a long-term follow-up. Because if we don't do the preparation correctly for the patient, we will discredit this technique.
Talking about that, we have an interesting study. Another one, I promise I'm not going to show much more, but this one, you're saying the right things. This was from 2020, obesity surgery, again, respectable journal from EFSO. And this one analyzed, this was a systematic review with meta-analysis, analyzed 11 studies, more than 2,000 patients. Take a look, ESG was very efficient, but the pooled mean excess weight loss in a year, the percentage at 18 months was 73%. 18 months follow-up. Now, it's important, like you said, to have a continuous follow-up program. To me, my ESG patients, my balloon patients, my endoscopic bariatric therapy patients are still my obesity management patients. We see the logo down there. We used to be called the Nacogdoches Center for Metabolic and Weight Loss Surgery. Not anymore. We're called the Nacogdoches Weight Loss Center. We are a comprehensive center. We are a center that takes into account every aspect of the patient's care, not just surgery. Surgery is at the end of the spectrum, but we also have management, medical management, and we manage patients with endoscopy. So we do lifelong follow-up. If you think about it, we are treating this horrible disease of obesity as we treat cancer. We do follow-up that is continuous. We continue to see the patients. We see them on an annual basis or more often, depending on where they are. Of course, the first year is more intense than that. We see them every 3 months or so. So again, a topic for another conversation with Professor Marano and Professor Vashist, but I don't want to take too long on this, but you are absolutely right. This requires multidisciplinary care. And it's not just, I'm going to do the procedure and goodbye, you're great. Not at all. And we make the patients also aware that they need to take their vitamins and multivitamins and iron supplements. We treat them the same way that we treat our surgical patients. I think that's very important.
Totally agree.
Now let's talk about the most fun part of the whole talk. I mean, we're surgeons, aren't we? So we love surgery. We love operating. So let's talk surgery. And we all know this, but for the junior members who are joining us in this wonderful, wonderful EFISDS webinar, and medical students from around the globe who are joining us, what are the indications for metabolic and bariatric surgery? We have, remember, this is a lot based on EFSO and FASMBS guidelines, and this changed recently 2 years ago. It used to be BMI of 40 or above. Now we dropped. It took us 3 decades in the United States. It took us more than 30 years to bring down the BMI 5 points. Can you believe that? And we did it, and we're so proud of that we can do much better. We can do so much better. But anyway, we brought it down to 35 because our patients deserve metabolic and bariatric surgery. And in the United States, it's very well known that of those patients who qualify, less than 1% have surgery every year. Can you believe that? Isn't that a shame? And a lot of that has to do with lack of education and fear and stigma. And so misinformation has a lot of that. That has a lot to do with that. And lack of insurance, lack of resources, socioeconomic status, etc., health disparities. So BMI of 35 or higher will qualify patients, or a BMI between 30 and 35 with obesity-related metabolic diseases. And we try not to call them comorbidities for the same reason. Remember, let's eliminate morbid from the vocabulary for obesity at least. So type 2 diabetes, hypertension, obstructive sleep apnea, GERD, osteoarthritis, polycystic ovarian syndrome. We can put them together, but we need some of those documented and well documented. And the patient must have a history and documentation of a successful weight loss attempts with more conventional, less invasive means, even though we perform minimally invasive surgery. And to remind the junior audience, metabolic and bariatric surgery is so safe nowadays that the risk of mortality is less than 1%, much less. And it's as safe to have metabolic and bariatric surgery as it is to come from home and have knee arthroscopy and go home the same day. Can you believe that? It's just incredible. Of course, I know you can believe it, but I'm talking to the juniors. Absolutely safe. Absolutely safe. This is one of the safest operations anyone can undergo, even though it's complex. And in the United States, at least, these are the procedures that are typically performed. Of course, you see the dots there. We have other procedures that are even endorsed by ASMBS, including the OAGB, or the one anastomosis gastric bypass. I'm just including the ones that are most commonly performed in the US. I'm talking about the sleeve, the Roux-en-Y, even though we're already doing OAGB, yes. I'm talking about the SADS. I'm going to show a beautiful video of SADS. And the biliopancreatic diversion with duodenal switch is not as common nowadays because SADI is taking the prize there. And then revisional metabolic bariatric surgery is going up. We're doing much more revisional bariatric metabolic surgery nowadays than we did before. And so we're becoming more specialized in revisional surgery. And also IFSO endorses many of these procedures and many more. And yes, we can talk about OAGB, we can talk about SASI, intestinal bipartition, jejunal-ileal bypass. Absolutely, we have members in the audience who can enlighten us with those procedures. I'm just mentioning the ones that are common in the US. Professor Abou-mrad, what about France? What about La France? What procedures are more common there?
Well, here in France, we have a severe restriction on the procedures, and the most common are. It depends also on the region. We have the two most common, sleeve and bypass. We are working on the bipartition with the sleeve gastrectomy in order to validate it. For our patient. I was a part of a multi-center study, and I performed myself nearly 50 cases. But we cannot introduce in France a new technique without having formally conducted a study and with the scientific measures and scientific norms in order to validate it. So we cannot do, even though we know it is beneficial, we cannot do, for example, OIGB because we had some issues with that. And the problem came from the lack of follow-up for our patients. So we had major issues. And so the government said, now, if we want to introduce new techniques, we must do correct studies, scientific studies, and the expert centers will take in charge the studies. So I think bipartition will come to the scene soon because we have a good result with it. But I know that there's some centers specialized in the duodenal switches and so on, but it is not commonly used in France. So the most frequent procedure are sleeve gastrectomy and bypasses.
Wonderful. And congratulations on having performed more than 50 cases of bipartition with sleeve. That's incredible. And I look forward to the paper and the presentation at SOFCOM and IFSO. And I want to be there to witness that. It's going to be important for all of us, including all of us in the United States of America, too. So this is talking about the US. This is a paper I'm very proud of. I participated as a member of the Clinical Issues Committee of ASMBS, which is the committee in charge of evidence-based standards and parameters and publications. This is the official committee. Proud to be a part of it. And I worked with Professor Abdelrahman Nimeri from Harvard College of Medicine and Professor Wesley Vosberg and others on the ASMBS statement on metabolic and bariatric surgery for beneficiaries of Centers for Medicare and Medicaid Services. What is Centers for Medicare and Medicaid Services? Well, of course, the United States does not have a socialized medicine system. But having said that, we do have a system called Medicare, which typically, if you think about Medicare, is you think about patients at the age of 65 or beyond when they retire, they have this system that takes care of their basic health needs. And so we pay taxes all throughout our lives, and I pay to Medicaid, I pay taxes to Medicare, so that when I retire, I will get the benefits of Medicare. Now, you could still have commercial insurance, but you still have Medicare. Medicaid aid is more about patients who have lower socioeconomic means. And so if you think about it, Medicare is for patients who have age of retirement. Medicaid is for patients who need more socioeconomic help, even at younger ages. Of course, it's more complicated than that. I'm just making it simplified. It's more complex than that. I'm by no means an expert in insurance, but just making it simple. But this statement has some interesting findings. Both the Medicare and the Medicaid population, so both the elderly or the more, I shouldn't say elderly, the more senior population or the population at lower socioeconomic classes, those populations will both benefit from metabolic and bariatric surgery. And it, as you said, it is actually cheaper to perform surgery on them and save money than it would be not to perform surgery and spend more money on their care for the rest of their life. And so, in other words, performing metabolic and bariatric surgery in those vulnerable populations, as patients who are senior citizens or patients with low socioeconomic status, have a profound beneficial effect compared to not doing surgery at all. So metabolic and bariatric surgery saves lives. There's no question about it. And it improves the DALYs, it improves the survival rates in our patients. So special thanks.
Oh.
Yes, Professor.
All
Yes.
good, all good, all good. I had just few queries, how long it's going to last, but I think you are at the end, if that's timely.
Yes, yes. We have probably 10 minutes to go. We're pretty much almost done. Is that okay?
Yeah, sure, sure. I mean, just I think people in audience just wanted to know. I had few messages coming in there. So yeah, now you have said
Yes,
it.
I knew. We knew we had 2 hours according to the webinar, so
no
we
issue.
did it for 90.
Yeah.
We
And
had
we
like
have
a 90-minute presentation, and then we can do Q&A.
No issue. Yeah, we have already few questions in the chat box.
Great, great. So yeah, we're almost done. And so special thanks here to the co-authors. This is Professor Marano, Dr. Professor Abou-mrad with me. We were in Frankfurt at that picture. Dr. Aman Goyo, who is phenomenal. He's one of our super leaders at TROGSS. And then Professor Adolfo Perez Bonet from Colombia, one of our wonderful educators. These are the co-authors for the following video that I'm going to show. And hopefully it's been submitted to FASMBS. We're hoping and praying that it will be accepted, but here is a preview of the video.
Robotics ADS, optimizing safety and technical considerations with triple use of ICG. We have no financial disclosures. We have a patient who's 53 years old with obesity class 5 who was an appropriate candidate for robotics ADS and typical obesity-associated diseases. And we present the triple use of ICG to identify biliary structures, to facilitate perfusion of the anastomosis identification, and for intraoperative leak test. The patient positioning is shown below in addition to the ports here, with one 12-millimeter port and the other ones being 8-millimeter robotic ports. Lower docking or pelvic docking was necessary to facilitate adhesiolysis. This patient had undergone prior pelvic surgery, and therefore it was very important to identify the terminal ileum without any adhesions involving it to avoid twisting or miscounting. And so to facilitate that, from the prior appendectomy, we had to perform adhesiolysis with a vessel sealer from a lower docking approach. Then we run the ileum distally to proximally from the ileocecal valve all the way up to 300 centimeters proximal to it. Then we mark that ileal loop and we fix it to the greater omentum in the right upper quadrant by using sutures such as Vicro. The double-ended suture represents the distal end or efferent, and the proximal end or afferent is represented by the single end. Then, while we could retract the left liver lobe with an external metallic liver retractor or other products, we strongly believe in the finesse and flexibility offered by the internal retraction offered by barb suture. So that's what we prefer to do. And that's usually enough to facilitate exposure of the angle of his and the stomach and the duodenum. Then we perform the gastric greater curve mobilization to enter the lesser sac while being careful to preserve the gastroepiploic arcade. We enter the lesser sac and then we aim distally. Normally for a typical sleeve, we would stop at 5 centimeters from the pylorus, but here we continue with a retrogastric dissection all the way to the retroduodenal dissection to identify with ICG the interface or boundary between D1 and D2, and also facilitated by identification of the gastroduodenal artery shown here in the picture with fluorescence. Here we can see the gastroduodenal in the middle of the screen. We can see the boundary between D1 and D2 with the flow of bile from the common bile duct into D2. We also identify and preserve the right gastric artery as much as possible, even though sometimes it's impossible to do, but most of the times we succeed. And we believe in preservation of that artery because that preserves the blood supply to the antrum and facilitates motility and prevents delayed gastric emptying. Once we do that, we mobilize enough of the duodenum and D1 and D2 that we can divide, and usually we can preserve 3 centimeters of duodenal bulb distal to the pylorus, which is enough to make a nice tension-free duodenal ileostomy loop anastomosis. Then we continue with creation of a gastric sleeve along the greater curve, separating and dividing the gastrocolic ligament while being careful to preserve the gastroepiploic arcade. And then the division of the short gastric vessels is usually not complicated except when we get to the upper pole of the spleen, and sometimes traction injury could cause bleeding, so we're very careful there. We use a 40 French calibrating bougie. Now, most of the times this is a relatively loose sleeve. We don't need to make it so tight, but it's usually a relatively loose sleeve, but using a 40 French bougie and using the vascular cartridges of the Sureform stapler proximally. Usually we use 3 blue, and then the rest of them are white, while paint.
I know what you're thinking. That duodenum looks a little blue. Please don't worry, I promise, I'm on it. I'm gonna show you the solution to the problem.
Paying attention to the AI algorithm for the smart pipe.
In fact, that's why I chose this video to show everybody.
Technology. Here we're using IV ICG, while at the beginning we were using ICG injected IV 90 minutes before, just like we do for cholecystectomy. Here it's just intraoperative ICG injected by anesthesia so that we can identify perfusion both to the distal stomach, which appears a little dusky here, which is not obviously not from ischemia, but from venous congestion, and also to identify perfusion to the DI anastomosis once we do it. Here we can see that the blood supply both to the antrum or the pylorus and the duodenal bulb, and also to the ileal loop is intact. So this is simply venous congestion on the duodenal side, and it's not really ischemia. We do a 1-layer hands-on, totally robotic DI anastomosis. We strongly believe that the single layer, well done, well fabricated hands-on anastomosis with the robot is advantageous, and it allows us to control, to visualize, to control for bleeding, to make sure that there is no stenosis created. This is usually a small anastomosis and just big enough to allow for passage of fluids and the food bolus, and it's not very large, and it's relatively easy to construct with the robotic technology due to the ergonomic advantages offered by the robot. And of course, we mix this with the use of ICG for perfusion. Again, this is not ICG injected 90 minutes before, which was the original injection to identify biliary structures. Now, this is ICG injected immediately, intraoperatively, live. And this is done by anesthesia per our request in order to visualize perfusion, to assess for perfusion. Once we do this hands-on, totally robotic, 1-layer anastomosis with barbed suture, we are ready then to perform the intraoperative leak test, and that is done with the 3rd use of ICG. Again, the first use of ICG was for biliary structural identification, injected IV 90 minutes before. The 2nd use of ICG, again, was live intraoperative immediate use, just like now, by injecting it by anesthesia to assess for perfusion, both for the stomach or the gastric sleeve and the duodenum and for the ileum, and for the internal portion of the anastomosis. But now, when we complete the anastomosis, we're about to clamp the afferent and efferent limbs, and then we prepare to have anesthesia insert an orogastric tube and a dilute concentration, a very dilute concentration of ICG, usually ICG mixed with 100 cc's of saline. We infuse it into the stomach lumen, and then we visualize under fluorescence the anastomosis, and we don't see any leakage of ICG, which is pretty sensitive. And finally, in the United States, we very commonly perform intraoperative leak tests to correlate. We certainly could just simply rely on the ICG for this part, but we prefer to use both modalities, and for training as well, and for our medical students and trainees. After we test the anastomosis twice, first with fluorescence and now with endoscopy, we visualize it, and it's a well-done anastomosis while seeing the pylorus, and across it we see the duodenal ileostomy. The patient did very well, was discharged to home without any complications, without her drain, and she was followed for 6 months. So CADS is very useful. ICU can be used with multiple uses, and surgical judgment is primordial.
I didn't have a lot of seconds to talk there, so I did my best. But just to finish up, of course, I don't need to explain this, multiple benefits of metabolic and bariatric surgery, but pay attention to the last one, the one in red. Yes, it reduces, many times it reduces the cancer-related morbidity and mortality that affects our patients. As a matter of fact, it's my pleasure to introduce this recent publication on behalf of TROGSS, the Robotic Global Surgical Society, where we had the honor of publishing on the outcomes of metabolic and bariatric surgery in populations with obesity and the risk of developing colorectal cancer. And very important, it was published in the prestigious journal Cancers from NDPI, and we found something interesting that based on the systematic review that we performed, that metabolic and bariatric surgery offers significant reduction in colorectal cancer and a potential reduction in risks for both colon and rectal cancer, but especially for women. It's very, very important. So we should think about metabolic and bariatric surgery as a modality or treatment, multidisciplinary therapy, not just to improve quality of life and reduce weight and control metabolic diseases, but also to prevent cancer. So this is a beautiful thing about metabolic and bariatric surgery. It has so many potential effects. We can not even begin to imagine all the benefits that it offers to our patients and to us. Having said all of this, I hope that we accomplished our objectives, which were 3 at the beginning of the talk. I really hope so. And we did our best. In conclusion, obesity is a disease of pandemic proportions. Obesity is not the patient's fault. This is very important. Not only is it a treatable disease, but the treatment leads to improvement, again, in quality of life and a longer life expectancy. That reduction in the DALYs. Among the most successful therapies are GLP-1 medications and other anti-obesity meds, endobariatric procedures such as the balloon or the ESG especially, and of course, our passion, metabolic and bariatric surgery. And if done with robotics, don't even get me started on that conversation because we can spend 3 more hours talking about that. And finally, the multimodal management of obesity has the potential to reduce, yes, cancer-related morbidity and mortality, especially with metabolic and bariatric surgery. So it is our deep honor and pleasure to be here with you, dear EFISDS, dear Professor Vashist, Professor Barano. We invite all of you to visit us in beautiful Orléans, the cradle, the origin, the original place of TROGSS, in the beautiful valley of the Loire in France. You can see the statue of Jeanne of Arc and castles, and Professor Abou-mrad will be a wonderful, splendid host for the Intercontinental Congress of TROGSS in 2027. Get ready for that. And of course, you're welcome to come to the beautiful state of Texas, in Nacogdoches, Texas, a beautiful place, a university college town, only 2 hours away from Houston. Any of you is invited to come here as visiting professors, and we'll learn from each other. So thank you so much. We're happy to take any questions. Professor Abou-mrad, any last minute words before the questions?
Well, as you mentioned it, you are all welcome for our Intercontinental Congress. It will be held on May 2027 at Orleans. So you are encouraged, and we will prepare something special for you. So be with us, and let's make it a good Congress. Because together we'll go further.
Great. It's a great webinar. I had already so many positive feedback, and it was so to a level insightful, because obviously it was a little bit long than usual, but you gave an overview, what are the current issues, and also the maybe the daily routine, the debatable issues that you have to overcome and consider before taking the patient for whatever type of intervention you decide to do. And that brings me to because this webinar series is not just to give the introduction, to go into really critical questions. Now, traditionally, scientifically, academically, if you want to adopt a therapy, a specific therapy, or you want to alter a therapy approach, what we have learned in the med school and in our science classes is the randomized controlled trial, because that one is the least biased type of investigation that we can perform. And you have cited many, many systemic reviews, meta-analysis. How much of bariatric treatment overall, and especially specifically bariatric surgery, is kind of evidence-based, that you can truly say it has a level of evidence 1A, 2B, whatever, you know?
Wonderful question. And it's a very, I'm going to let Professor Abou-mrad respond, of course, but this is a really critical question, Professor Vashist. I expected no less of you and Professor Marano, because at the end of the day, you warned me. The purpose of this webinar is not to just talk about an introduction, but it's to be critical. And the answer is it's becoming better. We can do better, Professor. We can do much better. We have so much to learn from our colleagues from surgical oncology. We can do so much better. We are getting better, I can tell you that. The example of the paper that we published with TROGSS in the journal Cancers, talking about that systematic review, the paper that we are publishing with you, multiple papers that we're publishing with you on artificial intelligence, that is much better evidence. We have umbrella reviews that we have published. Metabolic and bariatric surgery is getting better. Now, for years, for decades, we began by relying on little case reports and case series and level 3 evidence. And then we went on to level 4, I'm sorry. Then we went to level 3 and we relied on retrospective series. I showed a few of those here. Then we began to do prospective and level 2. And finally, we got into level 1. But to be honest with you, as you know, randomized controlled trials in metabolic and bariatric surgery are difficult to design. By definition, in surgery, it's going to be almost impossible to do a double-blinded randomized controlled trial in surgery, logistically speaking. And so now we're beginning to get more level 1. However, the systematic reviews that we're coming up with, a lot of them are based on observational studies, that they're not really based on randomized controlled trials, which is why I said, beware of that paper where they mentioned that endoscopic bariatrics plus GLP-1s equals surgery. Be careful with that. And I tell my juniors, be very careful with that. Be critical. That's why we do journal clubs. Because, you know, all due respect to the authors, but you can't just say that one thing is equal to the other just because you're basing it on observational studies. You need to perform an umbrella review. You need to do a systematic review of systematic reviews to be able to get to the solution and do more prospective studies. So to answer your question, we're getting better. For years, we have been dealing with MBSA-QIP as a wonderful database in North America. It's not just the United States that is participating in programs in Canada too. And MBSA-QIP is a wonderful database that has more than 1 million patients. And the data, and that's, yes, but however, it's based on retrospective reported data, and it's only as good as 30 days of outcomes. So what happens after 30 days? We don't know. So yes, it's wonderful in terms of numbers, but the numbers are not everything. The population number is not everything. The power is not everything. You need more parameters. Professor Abou-mrad, any comments regarding that?
Well, we have to consider two ways of thinking. The first philosophical way, saying that the good procedure or the good technique is that spreads fast and on the long term persist. If it spread fast, it can be from advertising or something like that, but it won't last long. But it's like if we compare laparoscopy to robotic surgery is taking the step, so it's a good thing. We don't have evidence-based medicine on that. What we are working on in France is we are working on some issues, but it's specific issues. We can't answer a general question. So we are comparing bipartition to bypass, because bypass is the gold standard. It's a prospective randomized trial. We had achieved the inclusion, and we are now studying the postoperative course. We are working also on diabetes with in person with obesity to measure the whole intestinal limb, and to see if the proportion of the alimentary limb compared to the overall length of the small bowel, and we are adjusting the biliary limb to see which configuration a long alimentary limb is good or better than a long biliary limb in treatment of the obesity. This is a prospective randomized trial. We are also working on sleeve. GERD in sleeve. If we fix the gastroplasty with the omentum, we do an omentopexy or not. Does it prevent GERD, or does it improve not having GERD or symptoms of GERD and postoperative course? This is also a randomized trial ongoing. So we try to do prospective randomized trials, but it answers specific questions. It does not answer the whole thing. So in the meantime, what spreads and persists and on the long course persist can be considered as a good issue.
Yeah, and the patient selection, if we, like in oncology, you know this patient is sick because you have a tumor that you can prove. Yeah, you can take a biopsy, you can prove that there's a tumor, there's a tissue alteration, there's something that should not be. I am not a bariatric surgeon, but obviously in our, where I was educated and during my clinical course, what I have learned, many of the bariatric patients on paper are much better than other type of patients. I mean, they have normal labs, they have normal cardiac function, they have, they may not be able to run 2 miles, but if you bring it down to the clinical testing, whether it being a pulmonary test, cardiac test, lab values, they do not perform very bad, but still they have an indication to undergo some type of intervention, whether it be endoscopic or surgical. So how do you ethically reflect this, this dilemma?
Yeah, I'd like to comment on that, Professor Vashist. Actually, I offer the counter response to that.
Okay.
Believe it or not, we are operating on sicker patients day by day, and I'm sure Professor Abou-mrad will corroborate this. So we are operating on patients who are ill. It's just that they don't have a diagnosis of cancer, granted. They may be younger than the typical cancer patient, granted. But we are actually now operating on older patients, more senior citizens, or patients who are sick. They have a lot of cardiopulmonary disease. A lot of them have cardiomyopathy. A lot of them already have the early stages of CKD. A lot of the patients have OSA, and many of them have heart strain, right heart strain. A lot of our patients have peripheral vascular disease. We are expanding the realm and domain of metabolic and bariatric surgery. And we can only do it, as Professor Abou-mrad said, with multidisciplinary care. Sometimes we work them up for 6 months. Imagine having somebody worked up for 6 months. And that's what it takes for all of the consultants to be able to not clear the patient. We don't say clear anymore. We say risk stratify and optimize, so that we can perform as safe a surgery as we can perform on our patients. But no, I mean, all of these patients are ill. Yes, there is a subset or population that we offer surgery on that is younger patients who are more functional. They're the ones who exercise regularly. It was like probably like me 3 years ago. I was I was active, you know, I wasn't looking like a cancer patient, but I was active. Yet I was suffering from obesity and related diseases, but I was functional. I was a subset of that group. I wasn't as sick as other people, but most of the patients we operate nowadays are very ill. Yes, we have younger 20-something, 30-year-old patients that we offer cash. That's another different conversation. Cash sleeves, cash bypasses. We can even talk about outpatient bariatric surgery, another beautiful topic to discuss. But most of the ones we're operating are very ill patients who are optimized as much as possible. What do you think, my friend, Professor Abou-mrad?
Well, we cannot say that all our patients don't have heart disease, don't have complications or diabetes. What we do is for every patient, we do a systematic screening for cardiopathy, for neurological problems. And so we take in charge the full patient. And sometimes, we must remember that hypertension is the disease related to obesity. So it can affect the heart. And to answer the question, do we have studies to have evidence-based medicine? We are working on a randomized prospective study comparing bariatric surgery to GLP-1 in patients with mild heart failure. So it's not yet set to start, but we are trying to imagine models in order to answer questions like you asked. So what is good is that after surgery, we have many patients in remission with hypertension, with better outcome for sleeping apnea, with better autonomy and better heart function. It's obvious. It's obvious.
I am with you. So I have obviously a lot of other questions, but for the sake of fairness, we should have few questions from the audience who they have. So someone is asking, is there any consequence about using canola oil for the balloon in case it is perforated?
Any concerns? This is a technique that is performed by some of my colleagues in Brazil. I think it's minimal if you think about it, because remember, the canola oil doesn't go before you do the endoscopy. It's the other way around. You do the endoscopy first. You make sure there's nothing wrong. You make sure that there's no perforation. I don't see why there would be one if the balloon's been there for 6 months and you're going in to remove it. The patient should be well enough to undergo the removal. You're doing a very thorough endoscopy before you commit to anything. And then you give a little bit of canola oil onto the balloon. I mean, if you compare canola oil to gastric secretions and saliva and bacteria from the mouth, I don't think if there is a perforation, the patient will get sick no matter what. I don't really think the canola oil may be that worse than saliva and gastric secretions and bile, but it's a consideration, of course. Yes, remember, this is done by colleagues who have done more than 40,000 balloon insertions, many more than I have done. And this was just a video courtesy of a well-respected, world-renowned endoscopist and bariatric specialist. But it's just multiple ways.
ESG, long-term outcome and revision after ESG. I mean, you said it, there are no long-term data yet, but yeah.
We're working on that. We at FASMBS are working currently on a consensus statement on that very topic. I can't disclose a lot of it yet, so to ruin the surprise, but it's coming. But I can tell you ESG is looking very promising. And as I mentioned before, the results are not as great as surgery, but almost. It's second place, I would say.
Okay, we agree that you provide us an e-print and we will mail it to all the participants, that paper.
Absolutely. Happy to do it. It's from the Clinical Issues Committee from FASMBS.
Nigeria, from understood that disease of obesity are subjected to one surgical treatment or other. Someone from Nigeria is asking that obesity is apparently subjected to surgical treatment, is there no room for diet, exercise, and other lifestyle modification in managing obesity in the mild or moderate group?
Absolutely, there is. As I mentioned at the beginning, it's a multimodal, multidisciplinary care approach. And absolutely, none of this works. None of this works if you don't have lifestyle. I mentioned it when I talked about my personal experience. None of it works if you don't have lifestyle modification and exercise and activity. It's a commitment for life. Surgery is just a tool in the whole spectrum. There is no substitute for nutrition and exercise and adherence to recommendations.
Okay, two more questions here. Do you do regular cholecystectomy during bariatric surgery?
Great topic. We used to, not anymore. And there is debate within the surgical community about that. But in the United States, it's not commonly performed at the same time unless the patient is symptomatic and, of course, has cholelithiasis or indications. Professor Abou-mrad, what about France?
Well, it's a question. We don't do preventive cholecystectomy. The question is if as we do ultrasound exploration of the liver and the gallbladder, if we find a asymptomatic lithiasis in the gallbladder, what do we do? Do we perform cholecystectomy before a bypass or not? This is the question here. So it's not evidence-based medicine, but I try to do cholecystectomy before, even if the patient is asymptomatic, because in case of bypass, because we don't have access anymore to the OD sphincter, so we cannot do ERCP. And this is a debate. If it is symptomatic, I do cholecystectomy surely before or at the same time as a bypass.
Okay, thank you. I missed this question because I don't know what's the context, but someone is asking, what do you mean by bipartition loop? I don't know.
Oh, that's wonderful. Professor Abou-mrad, can you explain what the intestinal bipartition is with sleeve gastrectomy?
Well, we perform a sleeve gastrectomy at first, and then we do a antroileal anastomosis, and the bowel is connected to this loop, this ileal loop, at nearly 1 to 1.5 meter away from the ileocecal valve. So it's a loop of nearly 2.5 meter, and the connection between the small bowel and the ileal loop is done at around 1 to 150 away from the ileocecal valve, and the anastomosis is on the it's on the antrum of the gastroplasty. This is the bipartition. We do have two circuits, one going down to the duodenum and then crossing the small bowel to the second anastomosis, the jejunal-ileal anastomosis.
Okay. I have a very provocative question, maybe. It may sound provocative, but I intentionally am going to ask this. Since it's a pandemic, okay, so if I had checked the WHO data in 2020, they said that 5 million deaths attributed to obesity and 40% of children below the age of 5 are categorized as obese. So if you demographically consider the development, the dynamics, so we are looking forward to more and more patients. So in the future, we have a couple of million annually to be treated patient. And why don't train all general surgeons for sleeve as a standard procedure and let them perform in every bariatric patient that fulfills the criteria of 30, 35 plus, just to do a sleeve. Because if the world is very different everywhere. So in West Europe or in North America, you may go just 2 kilometers or 2 miles of drive and have a bariatric center. In other places, if I remember the surgical access to surgical care from published in Lancet like 2 years back, it just demanded that some surgical experts should be accessible within 2 days of travel. So in terms of the global burden, accessibility, and providing medical care, why can't just we say that we fix like a sleeve as a standard procedure, and then according to the dynamic of the patient and availability of medical service, go with additional interventions in the future? It may sound stupid, sorry.
No stupid questions here. It's a provocative proposition, Professor. The only issue with that, though, is that selecting one procedure for the human population is not the greatest approach, simply because the sleeve will potentially have possible complications for many patients, including, and it comes to mind, the issue of GERD, and not only GERD, reflux esophagitis and Barrett's. As a matter of fact, FASMBS and EFISDS recommend surveillance on patients who have undergone a sleeve. At least 2 years later, they need to undergo an EGD or to make sure that we rule out such issues. And so we may be treating one issue for a whole new set of problems that we may causing to these patients who may not necessarily do well with a sleeve. The other issue is the genotype and phenotype and the response of the body to the sleeve gastrectomy. I just showed you a video on a patient who underwent a sleeve, beautiful sleeve. I could show you the original video, beautiful, well done, architecturally, well done sleeve, yet the patient experienced weight recurrence. And then you go back in, and I can show you the EGD when I performed the sleeve at the beginning. It was a beautiful sleeve, well calibrated with a 40 French bougie. Well, a year later, I go back and I see that dilated sleeve. What happened here? I thought I did a good job. And I can't blame it on the patient either. I can't certainly blame it on me, because I have the video that shows that I did what I thought was the right thing to do. So a lot of it is a sleeve may not be the best for everybody. And so we could say, what about doing a bypass on everybody? It's the same issue. So it's individualized. As you know, as a cancer expert, it's the same thing for you. It's an individualized approach. You can't really do one procedure and expect that everybody will do the same with it. And then you're talking about ethical implications. Maybe not everybody will want to undergo metabolic and bariatric surgery. Not everybody's psychologically ready. It's really interesting. It's an ethics conversation to be had, and we don't have an easy solution. Professor Abou-mrad, what do you think about this?
Well, to answer this, we cannot answer a complex pathology by simplifying the approach. So sleeves is not the answer to all the obese patients. And the sleeve has its indication and counterindication. So we cannot say, let's do sleeves for everyone. It is not possible. And it's not ethical, it's not logical, because we know some type of person does not respond to sleeves. They are relevant of bypasses or other technique. And we cannot be such selective in our approach. We are treating surgery, the consequence of a chronic disease. So the approach must not be as simple as that. And we must consider, as we said, the preparation of the patient, the follow-up, and all what goes with. So we cannot only operate and say, go and be on your way. It's not as simple as that. And as said Professor Oviedo, we have failure with the surgical procedure because the patient is not prepared. The patient is not aware of the condition to maintain the results of the operation. So it's not as simple as that. We don't say, oh, okay, go and do sleeves or do bypasses. It must be embraced by a public general health system and health policy to prevent progression of obesity.
Okay, we are way beyond 2 hours, and there are many, many questions unanswered. I can just give the feedback. People loved it, so I have so many positive feedback. I will close from my side and hand over to Professor Marano to have the last word. Thank you both very much. I mean, I can
Thank you.
screenshot and send you the comments. It's the people love it.
Thank you.
I just have the last question for Professor Oviedo and Professor Abou-mrad. Do you have in metabolic surgery such kind of pre-rehabilitation programs?
Yes. Of time, short answer, absolutely. We believe in prehabilitation. There is some debate. There are some groups out there and some researchers saying that prehabilitation is a myth and it does not work. It works. It works. In my personal experience, it works. On my patients, it works. If you think about it, what's wrong with preparing the patient as much as you can prepare the patient with nutrition, with exercise, with improved oxygenation, with mindfulness, with meditation, with everything you can do with natural ways so that they can undergo a successful operation? Professor Abou-mrad, your comments.
I totally agree with you. I think to prepare the patient is a must. To embrace all the factors related to his pathology is a must. And we must put on our side all what we can and all what we have in order to make the surgery a success. So I am totally, I totally agree with you. It must be, the patient must be prepared.
And do you decide the proper procedure on the basis of yourself, like a surgeon, or after a consultation of a multidisciplinary disease board?
Yes, so it's a surgical shared decision-making with the patient. And so it's a system, it's a conversation with the patient based on evidence-based algorithms. And we also use the artificial intelligence calculator, another topic, AI, artificial intelligence calculator from the American College of Surgeons and the FASMBS and MBSAQIP, which is a metabolic bariatric surgery accreditation quality improvement program. That was a mouthful. We use the calculator, which is available worldwide. Anybody can access it, that tells the patients the pros and the cons and the risks and benefit ratios and where they will be on their journey with weight loss up to a year and the rate of eradication or control of metabolic diseases. All of that for free. We utilize that, and when we decide. Now, we do not have a board personally in my program to decide on the surgery, but we do have, the decision is between the patient and the surgeon. However, we do have the specialists as part of the group that will optimize the patient as much as possible and do the prehab. However, in terms of revisional surgery, it becomes more of an intense conversation with the specialist because it's more of a high-risk procedure. Professor Abou-mrad, your perspective?
Well, in my experience, when the patient comes to me in order to be in the program, to be prepared for the surgery, and the first approach, I take my time to embrace all the factors related to his pathology. And I give him an advice on which surgery is the best fit to his case. And then after the 6 months to 1 year preparation, when we do what we call the commission, all the physician multidisciplinary approach sit at the table and discuss the case. We see if there is a counterindication for this or other surgical procedure, and we go with the recommendation. Then the patient comes back with the agreement of the council for surgery. He has, on my behalf, my patient I consider them as partners of their choice and partners of the project, because they are the most concerned person for this project, and they have the last word to say concerning the decision. I tell them, I think that the council said that. What is your choice? So the last words comes from the patient himself, and he decides. But he is aware of everything to be able to decide.
And here on this platform, I will take the last word now to end this webinar and allow Rodolfo to have at least last few minutes of the game where his son is playing and pick up him timely. So it was wonderful, both you having here. Thank you also to Professor Marano for joining over the weekend. I can send you a screenshot of the positive feedback and I will give you a detailed report, but I can surely tell that people liked it and enjoyed it, and certainly we will come back with a different topic. And yes, to the audience, they have all been asking, we will, together with TROGSS, create a nice certificate and send it to you. Thank you very much. Have a nice evening and a good day.
Thank you very much.
Bye.
Thank you.
Thank you.
Bye.
Thank you, Rodolfo. Thank you, Adel.
Thank you again.
Bye-bye.
Ciao.